Thank you to the PF Foundation for the invitation to speak today regarding navigating the process for lung transplantation. So currently there's about 70 plus lung transplant programs in the United States. And as you can see on the map, majority of those programs on the east side of North America. And so we'll reference that map in the next few slides. On any given day, there's approximately 1,000 patients on the lung transplant list waiting for that miracle, lung transplantation. And over the past years, every year we continue to do more and more transplants. Last year, I think we did approximately 2,600 in North America. Lung transplantation surgery is really offered to patients who have optimized therapy, medical therapy, but despite therapy, lung disease continues to progress. And so at that time, lung transplantation is essentially your only option at that point for continued treatment. It improves quality of life, and it also extends life. We usually offer patients when their current disease outlasts their survival, and transplantation can extend that. It requires a good support system from their family and friends, and we'll talk more on that. And lifetime commitment. After transplantation, I like to tell my patients, you and I become best friends. So essentially, I have a lot of best friends. It's a team effort for long-term success. Some of the most common indications for transplantation is interstitial lung disease. Within interstitial lung disease, the most common disease transplanted is idiopathic pulmonary fibrosis. Other diseases we look to transplant are patients with COPD, smoking-related lung disease, pulmonary hypertension, sarcoidosis, and bronchiectasis. How do you get to a referral process for lung transplantation? It really starts from your primary pulmonologist. He or she will determine that therapy is optimized, and despite therapy, disease continues to progress. Basically, referral begins with demographics, insurance information, and all the records that your pulmonologist has collected over the years get sent to the program, and we evaluate for consultation. When should one be referred, though? Ideally, we'd like to see patients who are deemed a little early for transplant or slightly within the window of transplant opportunity. It gives our team to expose the patients to the concept of lung transplantation, the requirements, and your expected outcomes and statistics. It allows also the team to modify any barriers that may lead to halting transplants so we can address concerns and get you to become a transplant candidate. Indications for referral are primarily determined based on the testing you have done over the years. So pulmonary function test, home oxygen evaluation, CT chest to determine the extent of disease and progression despite therapy. Echocardiogram is something that they perform to assess your heart. And throughout all this testing, you could see a trajectory of whether the disease is stable or progressing. And there is literature out there to help guide our pulmonologists to when to refer. But a lot of this is done by the transplant team and continued medical education in the community. Transplant centers, as you saw on the map, majority are on the East Coast, or halfway through North America on the right side, east side. For majority of the patients, you have the luxury of programs that are near to your home state or home country, city, and so you have options. So not so much identifying how many transplants a program does. Majority of the centers do quite large volume, but there are small centers that do a handful of transplants. And I think the biggest thing when patients go to transplant center is building a relationship with the team, and not so much how many transplants do you do, but do you feel comfortable with the team that's going to provide the care. Location and distance is important because majority of the centers will require you to be within a certain distance of the center so that when that opportunity for transplantation comes, it gives you enough opportunity to get to the hospital. And then post-transplant care. Majority, and if not all, require you to stay very local to the center so that they can continue to provide the care that they specialize in to give you the long-term success. Some of the things that we look to prepare our patients for the evaluation are 4 things: demonstrating medical compliance, exercise so physically fit, meeting weight requirements, and substance abuse abstinence. And we'll touch upon each one. So compliance. This is a team effort, 50% by your medical team and 50% by the patients and their caretakers. We want to make sure that we provide the care that you need, but also that you are medically compliant so that you can continue to get to the testing and have a long-term success. Vaccinations has been a big concern over the last 3 years, more than any time frame we've been doing transplantation with COVID. So we require that our patients are vaccinated. And you've seen over the last few days, patients who are vaccinated have a better success of surviving the infection than individuals who are not. So we really require our patients to be vaccinated, whether it's COVID, the flu vaccine, RSV, or pneumococcal vaccine. Exercise is extremely important. So I lecture to our patients during the clinic visit. I use the example, if you take two individuals, lung disease or no lung disease, and one adheres to an exercise program for an extended period of time and the other doesn't. The one that is physically fit will be able to breathe better and do more activity. So if you have lung disease, at that point you're dependent on physical conditioning more than ever to be able to breathe and do well. So early referral to your pulmonary rehabilitation program, you should get that from your referring pulmonologist so that you can start early and stay fit for, be prepared for a large surgery ahead of you. Oxygenation is an important concept because the fact that a lot of pulmonologists say, use 2 liters, don't use more. If you need more, don't exercise as much. But that leads to you becoming physically deconditioned. So our requirement is use what you need as a baseline so that you can exercise, keeping the oxygen saturations greater than 90%. Weight requirement. So we work very closely with our bariatric program. We identify patients who have a barrier to weight, as a BMI of 30 is usually our cutoff, but some patients will go a little above 30, but we utilize their services for medical weight loss programs, not so much surgical. So being active from that perspective is important, getting your pulmonologist to refer you to a weight loss program so that you can meet the requirements to become a transplant candidate. Substance abuse is an important one, of course. So we want all our patients to be off narcotics, illicit drugs, alcohol, tobacco, and we want at least a 6 months abstinence before we will consider an evaluation. Nicotine replacement therapy also falls within that category. We don't want patients on any form of nicotine replacement, whether it's chewing gum or patches, so that we ask all our patients to adhere to this. And pretty much every program follows these guidelines. Once you've had your consultation, you meet the basic requirements of transplantation evaluation, we'll begin the assessment. Lung transplantation is a big surgery, so the evaluation process is pretty extensive. So we want to make sure head to toe that all body parts are working well and that the lungs are the only problematic portion that we need to address. I use the statement, usually strong enough to undergo surgery, but sick enough to warrant it. A lot of the testing that we'll do is pretty repetitive from where you're coming from. Your pulmonologists have performed a lot of these tests, whether it's pulmonary function tests, 6-minute walk test, or blood gases. But we want the latest values so that a lot of the testing that we perform, there are variables within each test that we input into a score. And based on your score, you get listed. So again, a lot of these tests are repeated, but a lot of these tests are performed so that we can identify any issues that will lead to an unsuccessful post-transplant course. So CTs, we've identified new onset of cancers at the time of evaluation. So a lot of these testing is to assess, again, all body parts, kidneys, liver are functioning well and that you can have a successful outcome. Chest x-rays, all these other testing are performed so that we can size the organ appropriately. So when the time comes, we put the right organ in. Cardiac evaluation is important, obviously, that we want to make sure your heart is functioning at an optimal level. Every year we identify 1 or 2 patients who have coronary artery disease and that need stenting so that we can address these issues during the evaluation and then again give you time to recover from that procedure so that you have a, again, successful post-transplant course. GI testing is important. We want to assess for acid reflux and try to treat that before we move on to transplant, or address it surgically immediately post-surgery for transplant so that acid reflux is doesn't go well with transplant organs. You get a lot of lung injury, so that we try to address these concerns either early before transplant or after. Extensive blood work is performed so that, again, we identify the kidneys are working well, liver's working well. Cancer screening, specifically males, we do PSAs, so prostate screening. Infections such as hepatitis, now there's a therapy for hepatitis C, so that if anything is identified, we can treat it early so that it doesn't become an obstacle to a successful course. Age-appropriate screening, colonoscopy is important. So all these health maintenance testing for all our patients, we like them to be up to date. So get your colonoscopies routinely, your PSAs, evaluate with your primary care, breast cancer screening. Bone density is important. So we see a lot of our patients who are on prednisone for long-term reasons for your underlying lung disease, so that we can treat your osteoporosis early so that you're not developing fractures after surgery, and that you are also on long-term prednisone so that we can prevent progression of the disease. Skin cancer screening, more importantly in Florida than anywhere else. Dental clearance, we see a lot of patients, a handful, unfortunately, have pretty significant dental disease. And so addressing that is important. And then ophthalmology clearance because of cataracts, which is contributed by prednisone. You may have heard the term, it takes a village to care for our patients. So you can see all the number of consultants that are part of the care for your team, from the pulmonologist, surgeon, most importantly, our coordinators, social workers, so extensive team members that participate in the care of our patients. Financial considerations. You meet with a financial coordinator at all these centers, primarily for, one, do you have the transplant benefits to provide the surgery, but also our financial coordinator keeps our patients informed of what are your out-of-pocket costs, so medications. So working ahead to identify those barriers is important. Psychological evaluation, now that we've determined that medically and physically you're fit for surgery, we want to make sure that you're mentally strong to undergo surgery as well. So you'll meet with our psychologist who can determine whether there are barriers to which we could address anxiety, depression, get you on treatment so that you can have a successful recovery. Support system, extremely important to a successful outcome. As I said, it's a team effort. Between your transplant team and the patient, your caretaker is a big part of your success. So having somebody available to take you to doctor's appointments, taking you to testing, supporting you at home with your medications, caring for you pretty much 24/7. It's important to have a successful outcome. Now, once we've done all this medical testing, there are certainly things that we can find along the way that are relative contraindications that we can address, or absolute contraindications, such as newly diagnosed cancers again, or advanced heart disease. So along the way in your evaluation, unfortunately, there may be barriers to proceed, and these contraindications are sometimes not amendable to treatment. Once you've had the entire medical evaluation with your team, we present your case at our board meeting. Here we determine three things. Either you're approved for a transplant, and we go on to listing our patients, or two, you're deferred because we need additional testing to optimize your condition for transplant, or three, unfortunately, this is the toughest discussion we usually have with our patients, that you've been declined for transplant for these various reasons. These are some of the resources that you can look into, helping you understand what transplant's all about.
Thanks very much for asking me to speak on my passion, because truly transplant is my passion. I've done this since I graduated from college as a baby nurse back in 1982, actually with liver transplants. So this is my passion. This is our hospital. This is where we practice. We've got half of the third row back there are other coordinators that I work with. If you'll notice, we're on an island, which is beautiful most of the time, except for when there are hurricanes and you're worried about how to get on and how to get off the island. So that can be a bit of a problem. I have nothing to disclose. We're going to talk today about social support for lung transplant, a little bit about the evaluation process as well. As Dr. Patel has iterated and as other speakers have talked, about this. It truly takes a village. It takes a village on our part. Sometimes, most of the time, it takes a village on your part as well, social support-wise. Social workers are an integral part of our team. They are so important that during a 3-day evaluation period, our social workers are the first meeting of the day on that Tuesday. So that's as important as they are. We actually also sometimes have our social workers come and see patients even prior to considering them for transplant to identify any barriers that they may be working on until they get to the evaluation. So that works well. Our patients see social workers during the evaluation and even on an as-needed basis. So before transplant, while they're waiting for transplant, during their transplant hospitalization, and then post-transplant as well. So the social worker doesn't drop out after the evaluation process is done. She continues to follow them throughout their transplant journey with us. She helps with any needs that they may have. It's very important post-transplant that you get your medicine. So that's a huge priority for us. So we will ensure that you get your medicine. They also help with home health care, as well as sometimes even utilities and rent payments. So our social worker initial evaluation. When they walk into the room, our social worker currently, Emily Lover, we call them miracle workers as well, says, "I'm about ready to get into your business." And that's exactly what she says. And that's what she means. She's ready to get into your business. She wants to know, where do you live? Do you live in a single-story home? Are there steps? That's really important. I had a patient that we transplanted who lived on a house with stilts, and she had 26 steps to get up to a house that was 1 story. So that worked really, really well. We need to make sure when you go home from transplant that you can get up to your house. So we worked with her with physical therapy after transplant to make sure she could. How far do you live from the hospital? Can you stay in Tampa, close to Tampa, an hour away, for maybe a month after transplant? Can you afford to do that? And you need to know that that is one of the requirements at our center specifically. Transportation, do you have a car that works? Do you have access to a car that works? That's important. And then they do touch on insurance. By this time, the time you've gotten to the evaluation process, chances are we know that you do have transplant benefits, but what do those benefits look like? And how does that work? And how does the insurance portion of that work? They look at their admitting diagnosis, what kind of lung disease this patient have. When was transplant first discussed? Have you been thinking about this for 10 years? Or is this something brand new to you that maybe, and in the case of a patient recently, he didn't even know. His wife was the one that made the decision to proceed with transplant. He was intubated and on life support. So where are you in this whole process? And why do you want a transplant? I can't tell you how many times I've stood in a room with Dr. Patel and had him say to a patient, "Why are you doing this? What do you want to get out of this? What's the end point here?" I've been privileged to see people who have grandchildren, graduate their grandchildren from college, get married, do all kinds of wonderful things because of transplant. Why do you want to do this? What's the end game? What are you doing? Family of orientation, where were they born? Is your family alive or deceased? And do they have any childhood traumas or problems? Comes in kind of handy when your patient is sort of at the end of their coping mechanisms that they may have. That can be a problem. And so what things happened, what journey did you walk before you got to us as a transplant candidate? Family of procreation, so what are your relationships with your people? Do you have a wife? Do you have a person that you live with for 25 years? Those kinds of things we need to know. And the legality of those relationships comes in very handy when you want to talk about advancce directives, healthcare surrogacy, those kinds of things. Do they have any children? And will they be active with their care? So they may have a 28-year-old daughter and you think, oh, that's great, she lives close. She's got 2 kids, and one of them's 1 year old and the other's 3 and needs to go to nursery school, so they may not be great support. So those kinds of things are important. Educational and vocational history. What did they do for a living? What kind of a job did they have? Were they a kindergarten teacher who works with kids all day? Sometimes that's not such a great career to go back to. And do you even want to go back to doing that? That's the thing, the other piece of this. If not that, then what? And they can help you explore some of those things as well. What's their education level and what's their level of literacy? Very important, because we do transplant people who can't read. A lot of times it's a social worker that identifies for us, Lisa, I don't think that guy has a high school reading level. And that's what they'll say. We can do it. It's very possible to do, but it takes a lot of effort on the team part and on the patient's part to be able to do that. Lifestyle. Are they able to do activities of daily living by themselves, or did they come on a scooter to appointments and they need help showering and those kinds of things? As Dr. Patel said, it's very important when we transplant people that they're fit enough to be able to withstand a transplant, but yet sick enough to need one. They talk about home health care providers. Do you have home health in the house now? Who's your oxygen provider? Are you aware of your home health benefits if you have any? Because some people don't have home health benefits, believe it or not, with certain insurances. What are your hobbies? What do you like to do? Are they sedentary? Do you like to do crafting? That's what people tell me. I'm a crafter. I read. That's great. Or are you a skier? And do you want to go back to skiing and jumping out of planes and doing those kinds of things? It happens all the time. Do you have any financial concerns? What are your income sources? That's very important. We talk about literacy here as well. And then any legal history, any DUIs or anything like that that you've had in your past, we like to identify that. Your behavioral and emotional assessment, what's your mood like? Are you happy about this? This is the worst thing that could ever happen to me. What's your thought process? Is it goal-directed and focused, or are you a little bit scattered? Helps us to kind of plan our care and our education as well sometimes. Do you have any history of brain injury? So is there any kind of a traumatic brain injury that would influence the way that you learn or the way that you perceive instructions and education? The psychiatric history, the symptoms, any treatments or hospitalizations, counseling or psychiatry. Are you seeing a counselor at home, and do you participate in care with a psychiatrist as well? In some programs, a psychologist may see the patient. In our program, they do. In other programs, a social worker refers people to the psychologist for further evaluation. And then we talk about serial blood and or urine testing, which Dr. Patel alluded to. I have this on its own screen because it's very important. We talk about alcohol and tobacco use, both of which we recommend abstinence. If when you do your evaluation, we check your urine. We do a urine cotinine. So cotinine is a byproduct of nicotine, and we'll test for it. And if you tell me, I actually had a patient who went to the Hard Rock Casino, and he swore he didn't smoke, swore that he didn't, but his cotinine popped positive. And we did a little bit more research and found out he had been in a smoky casino the night before. So even those kinds of things influence that. Unfortunately, we weren't able to really prove that. We weren't able to verify that, so to speak, and he had a long smoking history. So we did 6 months of abstinence for him with urine cotinins that we checked randomly. And have they been in any transplant pre-treatment programs beforehand? So have you attended Narcotics Anonymous, Alcoholics Anonymous, those kinds of things? Sometimes that is mandated by our medical review board so that you have to complete a formal screening or a treatment process before we'll proceed. They do education regarding advanced directives, which is another important piece of this. They have the paperwork that can be filled out, but at least introduce that to the patient, the concept of advanced directives, healthcare surrogacy, planning for your future. They look at the support system, both primary and secondary, and people come to me and they say, Lisa, I have 10 people that will take care of me. 10 people. I don't need 10 people. I need 2 or 3 really good people who are very interested in your care. I don't need somebody who's employed by a nursing agency or something like that because they don't have skin or stake in this game, right? So I need someone who's close to the family. So let me give you my Pat and Mike example. I tell my patients all the time. 2 patients, or a patient, Pat and Mike. Mike was my patient. He needed the transplant. Pat was his wife, lovely woman. They lived in Lakeland, which is right outside of Orlando. So he was listed, and he called me one Monday, and he said, Pat fell and she broke her knee and she needed surgery. So I said, Mike, you just tell me what you need. Tell me what we need. Well, he said, I'm going to need you to make me inactive because I have to take care of Pat and get her to the hospital and those kinds of things. I said, that's fine. When do you want to do it? He said, surgery's scheduled for Wednesday. So we're going to go ahead. Just make me inactive Wednesday morning. I'll call you and remind you. I said, that's great. Not a problem. Very good. Guess what happened Tuesday night? Transplant. Yeah.
Cool.
So Pat's in the OR on Wednesday morning. It happens. Pat's in the OR on Wednesday morning. Who's their secondary support? A lovely neighbor who came like just right alongside, helped out, did what she needed to do with Mike's education, got Pat home from the hospital with her knee. So again, I don't need a lot of people. I just need people who are interested and who have a stake in your success and your well-being. What does support for transplant look like? So what do we ask patients to do for transplant? I don't need someone to take you to the toilet. I tell people all the time, they don't need to wipe the drool off your chin. They need to be able to remind you to take your medicines. I need them to come to appointments and hear instructions, because people on a lot of prednisone, sometimes they don't hear as well as we would like them to. So that's what I need from support people. They make recommendations, finally, after they see their patient, about possible risk factors. These might be the barriers to transplant. We might need to look at this. And then they also identify strengths. This is a problem, but they have this, so maybe that will be better. They also do education, and they give resources to our patients. So they do a plan, and then they discuss at our medical review board. Dr. Patel talked about what the medical review board says, yes, no, or maybe. So let's talk for just a little bit on financial considerations for lung transplant, because this is a huge hot button for us, at least, as transplant coordinators. We have financial coordinators that work with us. They actually have their own association, believe it or not. So these weren't people picked off the street. These are professionals who do this for a living. They assess the patient's insurance coverage, financial situation for transplant, and for immunosuppressive drug coverage. She's a key member of the transplant team. So when Dr. Patel goes around the room and does the round robin, social work, what do you think? Dietary, what do you think? Finance, what are you doing? Psychology, they're part of the team. They're the ones who say, approved with reservations, or they might say, has a financial fundraising goal of $5,000 and we can't proceed until we get there. So that's what they do. They educate our patients. These people come to us and they really don't, who would know their transplant coverage? They don't know how much their out-of-pocket is. They don't know about drug costs. We have the big three, the big four drugs, and drugs are expensive. Transplant drugs, the latest and greatest, and that's what we use, and they're expensive. So they need to know what's their responsibility with that, what's their out-of-pocket coverage with that. Patients are seen by our financial coordinator. Guess what order they are in they're number two. So the social worker comes in, and then our finance people come in. So that's how important they are. They're number two. They're seen during evaluation, while they're waiting for transplant, during their transplant hospitalization if we need it, and then post-transplant for any questions that people would have after about your insurance. I will tell you that we caution our patients before you change insurances, please let us know, please let us know. Not all Blue Cross Blue Shield plans are the same. We provide for some we don't, but we'd like you to stay with the one that we provide. That's important. The financial assessment. On this side, we have the things that are good. The income, the investments, annuities, IRAs, they get into your business too. And they want numbers, they ask questions. On the other side are the things, the bills, the rents, the mortgage, the water, the phone, all of that stuff, gas, health insurance, all of those things, all important to us to look at. And then they do an assessment, and it's like a weights on a scale. Do you have more coming in than you're spending going out? And that's important because there's people who are in arrears, actually. They look at the primary and secondary insurance, their out-of-pocket responsibility, so how much is this going to cost them a year to do? Prescription coverage, and then if there's need be, they counsel people about fundraising. GoFundMe accounts, Help Hope Live is another one that they use. And then they talk about private fundraising, church groups, civic groups, community people. Do you need to get on social media and make a plea? We've had patients do that as well. This is a typical finance note. So this is what we have. This is actually a patient that we recently transplanted. And she said, spoke to the patient on the phone to complete the outpatient consult. He reports income at $1,600 a month from Social Security disability. He states he lives at his mother's house and his girlfriend's house half-time, so he splits his time between them. He gives his girlfriend $300 a month, and mom's a little more lucky. She gets $500 a month for rent, car insurance, and payment. He does have sufficient funds to afford all of his monthly bills, but he expressed financial concerns. He states his Social Security has increased, and that was the first month that he didn't have to borrow money from his family. So, insurance consists of Humana Medicare Advantage plan with an $1,800 out-of-pocket cost to him that she explained in detail to him. I strongly advise patients to save for unforeseen circumstances, which is good, not related to medical insurance. Patient is, this is what we all want to see as coordinators, financially cleared for transplant, so we can go ahead. Putting it all together, the Medical Review Board presentation. Criteria for transplant, Dr. Patel talked a little bit about this as well. Absolute risk factors, things we don't want to see during the social evaluation. Active substance use or dependence, current tobacco use, vaping, marijuana, smoking, IV drug use. Not good. Risk factors that substantially increase the chance or the risk of transplant. Psychiatric or psychologic conditions, cognitive conditions with potential to interfere with medical adherence without sufficient support systems. We actually recently transplanted a patient that for 1 year needed to come back to clinic weekly to have his medication box filled and to get an attaboy pat on the back from his transplant team. So, and he survived. He had his year, he made his year. So we'll do anything that we need to do to support you. His support system that was fine during transplant got dementia. And so there was nothing, it was nothing that we could foresee, certainly, and nothing that he anticipated as well. So he needed help. So, and we were willing to do that and come alongside him. Unreliable support systems or caregiver plan, and a lack of understanding of the disease or transplant despite teaching. I will tell you that all of those things, as a transplant team, we band together to support our patients and to ensure success for that graft, for those lungs, because that's what we want to do. We need to find a good home for those lungs. Those are my references.
So thank you for letting me be here this morning and to share my experience on transplant with you. It is probably the biggest adventure I've ever been on, and I've seen a fair number of them. I don't have any disclosures, and when I get to the last slide, that may become a little bit more clear. But the path to my diagnosis started in the fall of 2016. And my general practitioner had never seen a case of pulmonary fibrosis, let alone idiopathic pulmonary fibrosis. And that is not as uncommon as you might think. They diagnosed me with pneumonia, and we were getting prepared to take a vacation, and they said, "We'll see you when you get back from France." We went and spent a couple of really nice weeks that took us away from all of this and any concerns we had about what was going on with my health. And then on January 31st, 2017, at about 11:30 in the morning, I sat down with Dr. Stephen Nathan, and Dr. Nathan said, "You have idiopathic pulmonary fibrosis. I'm going to give you about 2.5 to 5 years of what your life expectancy is, and I want you to get your affairs in order." And then he paused for just a very few seconds. And he said, "But here's what we're going to do." And he laid out a plan. And that plan is the reason that I'm here today. So we went through a whole lot of interesting things. We started me on oxygen in late 2019. And I'm sorry, I'm going to ask just for 1 second if you'll accommodate me, because that alarm I set every Veterans Day to recognize the 11th minute of the 11th hour of the 11th day of the 11th month. And that just occurred. So the team put me forward to meet the Transplant Review Board. And I did that. I went through all of the testing. I was approved for transplant in March of 20, but as Dr. Patel said, sometimes the answer is we want to defer you. So 2 things were happening in March of 2020. I wasn't quite sick enough that a transplant was urgent, but that was also the time that COVID was showing up on the scene. And putting a lung patient in a hospital that was about to be overrun with COVID was probably not a solution that was good for the plan. It was almost a year later, March of 21, I had gone from 2 liters of oxygen at rest and 4 liters for exercise to 7 liters a minute of oxygen to walk across the room. We had more tubing stretched throughout our house than, we looked like a gas station. But we were in March of 21, they said, it is time to get you on the list. And I was put on the list in mid-March. And I got the call on July 9th, 2021. The Today Show was on. There's some moments in this process that you're never going to forget. The Today Show was on. 3 of the nurses in the center called me and said, we've got a lung offer for you. And they took a picture of that moment, and I still have that picture. And it was absolutely, my wife and I were in the car headed, and we live about 2 hours from our transplant center. We were in the car headed there, and I had spent an entire career in law enforcement. And she said, slow down, you're going to get in an accident. I said, well, today it will be a hit and run. So I went into surgery the next day. I have actually rehabilitated lungs inside. My lungs went through the EVLP process. The doctors, my surgeon, Dr. Daniel Tang, said there's a little bit too many gases on your lungs right now, so we're going to send them for rehab. They watched it. 3 o'clock on the morning of July 10th, I went into surgery. My wife, Susan, who's in the 4th row back here, who last night somebody at dinner said, I'm glad to see you brought your daughter with you. What? So it was July 10th, 3 o'clock in the morning, she kissed me and said, don't screw this up. And I went into surgery, and it was about noon when I came out. They woke me up on the 11th, and once they did that, we were off to the races. I was transplanted on July 10th. On July 20th, they sent me home. So 10 days, and part of that is what I'm going to get to next. That was the before and after. And I'm going to see if I can find the laser button. If you look here in this picture, you'll see the wires that are holding my chest back together. They did a sternotomy, and it was very effective. And I tried to carry that picture around in my wallet, and I gave up. I do carry it around on my phone, though. So it was urgent. But I wanted to tell you the whole reason I was here today. Transplant's a very personal decision. It's not for everybody. Each of us is unique on this journey, and we all have to be prepared for what lies ahead. And all of the things that were mentioned here about being ready and building your village are all important. But I want to tell you the secret of being prepared for transplant. Does anybody know what it is? It's been mentioned here already. Listen to your care team. I promise you, they will get you through this. They've done this before. If you're lucky, you're going to do it once. Well, there's one person in this room that's done it twice, that's sitting in the back there. But you're going to do this once. And they've done it over and over and over again, and they're going to help you get through this. Listen to them. My care team at Nova Fairfax Hospital in Falls Church, Virginia, their advanced lung disease and transplant clinic got me through that. We had, when I went out on disability in 2017, we moved to our retirement home, which is between Richmond and Charlottesville. It's about 2 hours from the hospital. We drive past 3 other hospitals so we can go back to that center every time I need something. I don't care if it's labs, it doesn't matter. We're going back to that center. The 4 things that I will tell you in the time I have remaining. The testing is important. They want you to be healthy enough. They want to identify and correct anything that shows up during that testing. And I had to actually go through some of the tests twice because I was deferred. The most fascinating test to me was the double heart cath, because I get to lay there and watch that wire run throughout my veins. The one that was the weirdest for me was pH manometry. Because of the Nova, they only do that in a pediatric clinic. So I'm 5'10", and I was about 200 pounds at the time, sitting on a chair that was made for a kindergartner while I waited in the waiting room. Pulmonary rehab and independent exercise, I walked up until the day before I got the call, and I was walking every day at that point. Learning to breathe again, I laughed when they first told me that in pulmonary rehab, but they did teach me to breathe again, teach me how to breathe to be prepared for transplant. Stamina and conditioning were important, and COVID. Pulmonary rehab in person transitioned to a more virtual format at the beginning of COVID, so we had to adapt to that. Attitude. I wrote in my journal, be positive in all things. That was part of the mindset. Psychological testing was mentioned this morning. If you become a victim to the dark corners of your brain, you're going to make it harder to get yourself through this process. And ask for help if depression or anxiety becomes an issue. Even if you don't see it, if the person, your partner, sees it, if your caregiver sees it, listen to them. And then a village. Susan, my wife, who I said is in the fourth row, created our village. She brought together people. She brought up those backup caregivers, one being her sister and another being a very dear friend, who showed up for patient education before they would let me go home. And prepare for the unexpected. It is going to happen. I have been very fortunate. I've only had 2 relatively minor exacerbations. And then my left bronchial stem since then has started closing up. So they've had to put a stent in. But all those things are manageable. I can live with those. And I got to tell you, the outcome on the other side, that was November of last year, standing in Yosemite Valley in that snow after it snowed 5 feet the night before. And that was worth it. That motorcycle, when Dr. Nathan told me to get my affair in order, I had sold a collector's edition Harley Davidson because I didn't want Susan to have to deal with that. 2 months after I got out of the hospital, that red Road Glide Special has a Donate Life license plate that says breathe. So if you ever see that, that's me. Wave. And then finally, that was Ranger and I in the Smoky Mountains. Ranger, I didn't put that picture up there because I didn't want to ask anybody if it makes my butt look big. But being able to get back on a horse again and ride was absolutely one of the best parts. And I have hit 0. It's back to you.
Good morning. Thank you for allowing me to share a little bit of what went on for me. The journey is, this is a progressive, non-predictive disease, and my journey is different maybe from someone else, but we all are on the same journey, just in a different way. Sam had one experience, the doctors talked about, the process, and I didn't believe that I had IPF, even though my brother did. So in my case, it's familial, but I was not having that. And when my brothers died of that, I was not having that either. So I found a way. I had a VATS biopsy to confirm that I had it, and moved on to find a transplant center recommended by my pulmonologist. So I took out I went on the computer and found all the different doctors that were at the centers that I was considering, which was Columbia and UPenn. And in deciding that, I decided that I would get the dorkiest looking doctor at UPenn because he probably studied in college. But I learned by doing that you have to stay the program. You have to be physically fit. You need to be getting help with breathing and doing pulmonary rehab. And unfortunately, that only lasted about 12 weeks. So then I went out on the web and found pulmonaryrehab.com and worked on Zoom with David Younga and kept it going. And that was good because it made me committed to the process. So even though I was in good shape, I was a kayaker and very physical in my life, I needed something that was teaching me all my breathing techniques and keeping me in tune with getting ready for what was eventually going to be, it turned out to be a transplant. Now, I'm in a support group. I'm saying I'm not getting a transplant. I'm waiting for a cure. Science is moving fast. And that was my MO. I just said that at every meeting. And then in 2020, things went downhill very fast, even though it was COVID, as Sam said, but I wound up at UPenn getting a transplant. But what wasn't mentioned here is sometimes you have a dry run. And a dry run is you get the call, you think you're getting transplanted, you go to the hospital, you wait, you're waiting for the lungs, the nurses are telling you, yes, you're still having surgery, it's an hour later, yes, you're still having surgery, and then you get a call, the lungs weren't viable, go home. And for some people, that goes on and on for a few times with transplant. The second time I got a call in 2020, about a month after that dry run, I knew it was pretty serious because they had me right into pre-op. So good, I'm gonna get this transplant. And I was very, very calm because I really believed in the process. I believed in the surgeon. I had spent many time with the team, as we all talked about. There's a village behind you, and they have checked out your finances, your habits, your way of life. So I believe in living life and having fun. And even when I was sick, I got that oxygen concentrator and didn't let it stop me. I traveled Italy, France, Alaska, you name it. I was on the go with my oxygen. So I don't have slides because it would just be pictures of me, and you don't need to see that. So, once the operation happened, I was in intensive care, as everyone is, and I was out in 2 days, which was pretty good. But what I want to mention was they get you up to walk, and the first thing you do as you're going down the aisle is like, where's my oxygen? You think you need it, and it's a little disturbing. The other thing is you don't know if you were out for an hour, a day, a week. I mean, it is such a huge time that time passes, and I'm trying to signal to my daughter, like, what time is it? What day is it? And you're intubated, and I'm like doing all these motions trying to do sign language to get her to tell me this, and she said, Mom, you better calm down or they're gonna kick me out of here. So I brought whiteboards, because in office products I have all kinds of stuff, and said to the team, here, these should be, every nurse in the ER should, in the ICU should have these, so they can write the day and time and hold it up for the patients so they know exactly where they are and what they were. But at the time I had Dr. Andrew Courtwright, and he said, I told you, you just don't remember. So I believe that doing meditation and seeing therapists during the process is really important. To stay positive, as Sam said, is key. You just have to stay really positive. And for people in my group, I will say that some of them had to go to 2 or 3 centers till they were accepted. I had a bout of a lumpectomy that held me back a year, and my process was 7 years. So I'm so blessed that now I've got my life back, and I thank you for being here.